Okay, well, my name is Rob Hendrickson. I am the program director for the Medical Toxicology Fellowship at OHSU, Oregon Health and Science University in Portland, Oregon. And today I will be talking about chelators. And the etymology of the word comes from the Greek and Latin, and it means claw, and which is kind of interesting because, as you'll see as we go through this, many of these chelators actually act like claws and grab metals, and that's sort of the basic idea of chelation, that there's one or a small group of chelators that will go and bind to an object, particular metals, in some sort of stoichiometric relationship. And usually it's one chelator to one metal, but sometimes, as you'll see, there'll be different combinations. There's a couple of things that are in common with most chelators, and you'll notice that most of them have a carboxyl group or a nitrogen group or a sulfur group, and those are the things that are binding to the metals, and they tend to form cyclic structures. They tend to form stable metal ion chelate pairs, which are then generally urinated out, although sometimes in the fecal material as well, they're generally cleared from the body. And that's the whole purpose of chelation, is someone has a metal, and we want to decrease the blood concentration of that metal, so we give them a chelator. So a couple of other commonalities amongst most of the chelators is very small volumes of distribution, which suggests that these really stay in the blood, in the vascular compartment. We are generally using, there is one exception, deferoxamine. It can travel into the interstitial space and into hepatocytes, but most of the chelators stay in the blood. What our intent of chelation is to decrease blood concentrations. And then once the blood concentration is decreased, then we draw some of the metals from the other compartments. And for that reason, you'll see rebound of metal concentrations. But it's important to recognize that we are not chelating other areas, other organs. We are chelating the blood, and that's really the take-home message for chelation. Is the purpose of it is to rapidly decrease blood concentrations of a metal in people who are sick. It is not to go and decrease the total body burden of a particular metal. It's not particularly good at that. What it's really good at is decreasing blood concentrations, and doing so rather quickly. These all have relatively short half-lives, and they form stable ring structures. And a couple of examples, this is in the upper right is the BAL and binding to arsenic, forming a ring structure, and then the calcium-sodium EDTA on the bottom there. Now, like all great lectures, there's always a heavy metal band that's associated with, and I can't attest to chelation intoxication's music. But what we will be talking about today is the following, and you see that there are a lot of chelators here. There are a lot of confusing names that look very similar to each other. There's a lot of acronyms. So what I will try to do is try to go through each one and try to give you the take-home points, what they're used for, what the specific toxicity is, and how they're used. When you do look at the chelators together as a group, and this is certainly not every chelator in the world, but these are the ones that I'm going to be talking about. These are the ones that you're likely to use. You can group them together. There are the short carbon chains with sulfur groups or thiol groups on them, like in the upper left, that's D-penicillamine, DMSA, DMPS, and BAL. They structurally look somewhat similar. It turns out that they are functionally somewhat similar in that they mostly are going to be used, or at least are effective in chelating mercury, arsenic, and lead, so similar compounds as well. On the bottom, on the left, longer chain carbons with nitrogens and a lot of these little arms with carboxyl groups on it. That's DTPA and EDTA. And then on the upper right is Prussian blue, which has a very, very unique structure. It's really fascinating. Iron group with 6 cyanides branching off of it. And then finally on the bottom right, this is sort of caterpillar-like structure of deferoxamine, which is fairly unique. So let's just go through in order, starting with dimercaprol, or BAL. It's often called BAL, and that stands for British anti-lewisite. This was actually developed as an antidote for lewisite, which was a irritant gas and a pulmonary agent, but is now mostly used for lead encephalopathy and severe lead toxicity. The chemical structure is on the right there. It's a short-chain hydrocarbon with 2 thiol groups. So thiol groups are S and H, so sulfur-containing groups. And the longer dimercaprol is actually a shortened version. It's actually 2,3-dimercaptopropanol. And this is one of those you can actually figure out as long as you understand that mercapto is the same as thiol, which is an SH group. Propanol is a 3-carbon chain with a hydroxyl group on it, and then the 2 thiol groups on it. So this one actually you can figure out from the name. Unfortunately, most people call it BAL, so that makes things somewhat more difficult. This is a very unique medication in that it is dissolved in peanut oil. And while it is actually somewhat water soluble, if in aqueous solutions it oxidizes, and so it's always put in peanut oil. Becomes an issue when we talk about people with peanut allergies. It also is rather painful. And the peanut oil itself actually smells and can actually make your patients smell like peanuts after they get it. The indications are really mostly for lead encephalopathy. That said, there's been a lot of use in the past. There is some potential use for inorganic mercury and also for specific arsenic syndromes. So I want to go through those specific indications and make sure that we're all on the same page as far as what the concerns are, what the issues are with potentially using that in those. But I think the take-home is that BAL is generally used for lead encephalopathy or severe lead toxicity. So BAL binds to arsenic, as you can see, with this making this nice cyclic structure, and it's a bridge between the 2 thiol groups, the 2 sulfurs. So one of the unique aspects of BAL is that it's only given deep IM, and so no IV use, no oral use, and this is rather painful with the peanut oil. It's somewhat high volume, and can pose issues with patients being a little reticent to get additional doses. You imagine getting multiple doses of deep IM injections through over several days. It's despite its IM. It being given IM, it peaks very quickly, about 30 minutes, it stays at a high concentration for about 2 hours, and then very rapidly drops off with a fairly short half-life. And dimercaprol is glucuronidated in the liver, and that's how it's cleared and metabolized. The dose is somewhat different, but for different situations. But in general, it is 4 milligrams per kilo IM, or 75 milligrams per meter squared in children. And a lot of these chelators have these meter squared or milligram per kilogram dosing. So I figured them out for small weights for 10 to 50 kilos, and that's on the bottom right there. You see that at really small, at 10 kilos, 20 kilos, the doses are pretty similar. But when it gets up to much higher, like adult size, 40, 50, 60, 70 kilos, the 4 per kilo is actually quite a high dose and much higher than the per meter squared dosing. That becomes an issue because adverse effects are dose-related and has a fairly narrow therapeutic window. So this is important. This is one of those important medications that we take the time when you're dosing it, to, 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 So let's just go through mercury and then arsenic and lead, because I think it's important because there's a lot of sort of mixed messages. And, if the question is, does BAL bind or chelate mercury, the answer is yes. There is an old study that looked at people who had ingestions of mercuric chloride, and they treated with BAL, and they all survived, and they compared them to historical controls, and the mortality rate was about a third. And so that was thought, well, maybe this is effective, and it very well may be. One of the issues is with mercury is that it does cause a significant amount of redistribution. So if you look at the bottom right, the figure, those are two mice that are sectioned. On the right is the tail, on the left is the head. The first mouse on the top was given radio-labeled mercury, and you can see that it's accumulating somewhat in the liver and in the kidneys, and then the bottom was given BAL in addition to mercury, and you can see the liver and the kidneys are still lighting up a bit, but that area on the left here is brain tissue, and that is and that is the evidence that BAL redistributes mercury into the brain. So we generally don't recommend it for things like organic mercury or elemental mercury vapor, which is the ones that we would typically see, but there is potentially a role in inorganic mercury toxicity. Arsenic, again, the answer is, does it chelate? Yes. Does it increase urinary excretion of arsenic? Yes. And in animal studies, decreases LD50, but also redistributes arsenic into the brain. And so, in general, BAL is not generally used for arsenic, although there are probably some specific arsenical problems like encephalopathy or arsenical fever where BAL may be effective. And then lead. Lead is chelated by by BAL, and not only that, but using BAL in combination with calcium sodium EDTA is more effective than using either agent by itself, and that's demonstrated on the graph at the right. The upper line is EDTA. These are blood lead concentrations, and then the solid line is using BAL in addition to the EDTA. So this is where we're going to see BAL used mostly. We're going to see it BAL used for severe lead toxicity or lead encephalopathy, and generally BAL is used 4 hours prior to calcium sodium EDTA because calcium sodium EDTA may redistribute lead into the brain, and BAL will inhibit that effect. So there's a lot of issues with redistribution into the brain as far as BAL goes. The issue is with arsenic and mercury, and not with lead. So there are a lot of adverse effects, and the adverse effects are quite dose dependent. The higher the dose, the higher your rate of adverse effects. There are some unusual adverse effects that are fairly common. There is this pretty common side effect where patients will get lacrimation and salivation, kind of sludge-like symptoms. They get rhinorrhea. They can get a hyperthermia. They get burning of the eyes and mouth, and get muscle aches and tooth pain. They get very, very anxious. This usually happens a couple of minutes after the injection, and generally resolves over an hour. So it's important to recognize that this, and almost expect that it will happen, and even tell the patient that it might happen. In fact, up to 30% of children who get BAL will get an elevated temperature. This is not, if it resolves quickly and there's no other signs of infection, it should not initiate a workup for infection and those types of things. And higher doses have a very high rate of severe side effects. So it's important to take the time, if you're ever giving dimercaprol or BAL, stop, check your math a few times, make sure you're giving the right dose. We want to give enough to be helpful, but we don't want to give more than that because it quickly increases the adverse effect rate. There's a couple of contraindications. Someone who has hepatic dysfunction because it's metabolized by the liver, of course. Someone with peanut allergy, that's pretty straightforward. There is some evidence that giving bicarbonate infusion to increase urinary pH may ion trap the BAL chelate, and is reasonable to give bicarbonate to people who are getting BAL. And then, this is true for every chelator. They have different binding abilities for the metal you're trying to chelate, and then other metals or other minerals. And zinc is a very common thing to chelate, sort of by accident, and so you can get zinc deficiency if there's if you're giving someone BAL for a long period of time, and that's true for most chelators. And then, interestingly, so we often do give multivitamins and things like that, but with BAL, iron BAL complex can lead to severe vomiting, so we tend to avoid giving supplemental iron in these patients as well. It comes in these glass ampules. It's yellow, it's viscous, it smells like sulfur and a bit like peanuts as well. And the ampules come in 300 milligram ampules. So let me move on to the next chelator, which is EDTA. Now, EDTA comes as calcium disodium EDTA, and that's what we're going to use almost all the time. It's important to note that it does come as sodium EDTA, disodium EDTA. The reason why that's generally not used is because it can lead to hypocalcemia. And so generally, when we use EDTA, it is for severe lead toxicity, and generally we'll be using calcium-sodium EDTA. It's an important thing to differentiate. It has been in the past somewhat common for practitioners, naturopaths, and things like that to use disodium EDTA and run into trouble with hypocalcemia. So most of the time we're going to see this used as, or we're going to use this as for severe lead toxicity. I want to touch on one other aspect, which is kind of interesting and we run into occasionally, and that is this thing called the TACT trial, which looked at could we chelate with disodium EDTA patients who have high risk for myocardial infarction, and could we decrease their rate? The idea here is that it would bind all that calcium in those atherosclerotic plaques and decrease their risk of getting worsening cardiovascular disease. So, interestingly, it was a very large NIH study, and it was 1,700 patients, over 100 sites. It was patients over 50 with an MI, with no recent revascularization or smoking, and what they did was they gave them, I think about 40, if I remember correctly, 40 3-hour disodium EDTA infusions, looking for endpoints. And so here's their clinical endpoints slide, and I bring this up because it's been it's often misinterpreted. So if you look at the individual endpoints like death, the rate is the same, statistically and clinically equivalent. Myocardial infarction is the same, stroke is the same, hospitalization for angina is the same. There's a little bit of difference, a 3% difference in coronary revascularization, but it's not statistically significant, and it's borderline if that would be clinically relevant. But if you, as is common with cardiovascular studies, if you combined all of these numbers together into the primary combined endpoint here, you get something that's 4% difference, which is statistically significant. So this has been this was a positive trial if you look at the primary combined endpoint for all cardiovascular issues. But if you look at specific data for death and MI and things like that, there really was no difference at all. So we do occasionally still see people getting disodium EDTA to decrease the risk of MI or recurrent MI, and that's the data that it's based on. So like other chelators, very small volume of distribution, half-life is short. EDTA is renally cleared, and renally cleared very quickly. The half-life is quite short. So the primary use for this is lead encephalopathy. There's a milligram per meter squared per day dose, 1,500 milligrams per meter squared. There's also a milligram per kilo dose, and I put those in the upper right again. That's small when you are in small children. The dosing is quite similar. When you are get larger, 40, 50 kilos and up, the doses differ significantly with the meter squared dosing and the milligrams per kilo dosing. So generally, for adults, the max dose for lead encephalopathy is 3 grams, and for asymptomatic lead elevations, it's 2 grams in adults and 1 gram in children. So those are good starting points, but this is, again, is another great medication to just stop. We don't use this very often. Stop, do the math, double check it with a pharmacist to make sure you're given the right dose. So the package insert says these infusions should go in over 8 to 12 hours. Generally, what people do are they calculate the per day dose and then just infuse it over 24 hours. Doesn't seem like it's reasonable to give it over 8 and then do nothing for 16 hours. So again, this is renally cleared, so make sure urine output is established before giving it. And there is some evidence that potentially giving things like folate and pyridoxine and thiamine may increase efficiency. It's not very good data, but it's commonly used, so just so that you're aware. It is certainly effective. It reduces lead concentrations in blood and bone and brain. It actually has one of the few chelators that actually has a functional endpoint difference. It actually reverses lead's effects on heme synthesis. So this is effective. The downside is that it redistributes to the brain initially. And if you look at the bottom of the screen, this is a study looking at lead concentrations in animals that were given saline, and then animals that were given calcium sodium EDTA, and these are brain concentrations increase significantly with a large dose of calcium EDTA. Now, this is a larger dose than we normally give to human beings, but the point is that there can be some redistribution into the brain, and that's the reason why we generally give BAL first before we start EDTA. It's important to note that even the best chelation only removes a couple of milligrams of lead, and that's probably true for all chelators and all metals. You know, our intent for chelation is not to eliminate the body's burden of, say, lead in this case. The intent of chelation is to rapidly decrease the blood concentration to try to make someone acutely better. And in studies that looked at trying to eliminate all of the metal from the body, generally this is not very effective, and it only removes a very, very small portion. This was a study looking at children with severe lead toxicity, and they were able to, you can see, with BAL and EDTA, were able to remove about 5 to 20 milligrams of lead over a 24-hour period, and these were patients who had very, very severe lead encephalopathy. And we're not, I think it's important to recognize that when we do chelate, our intent is to rapidly drop the blood concentration, that the total amount that you're going to remove might be 10 milligrams of lead, and they may have tens or hundreds of milligrams of lead in their body, which is going to be difficult to chelate in an acute session. So what are the adverse effects? So they are somewhat dose dependent, and generally nephrotoxicity is the most common, or worrying at least. 13% develop renal insufficiency, 3 develop renal failure. Most of this is transient, and very few people require hemodialysis. So it's thought that maybe this has to do with EDTA chelating lead and then presenting it to the kidney, where lead is clearly a nephrotoxic agent. So this may be somewhat dose dependent as well, and that is borne out by studies that looked at. If you limit the EDTA dose to that 1 gram in children and 2 grams in adults, your rate of nephrotoxicity decreases. So that may be a way to decrease the rate of nephrotoxicity in those patients. The symptoms, the side effects are unusual, as is the case with many chelators: myalgias, headache, lacrimation. Occasionally, people will get a transient hypotension. The longer infusions can chelate a fair amount of zinc and lead to zinc deficiency. This would require multiple days of infusions. This is not something that will happen in the first 24 hours or anything like that. But it often leads to these zinc deficiency symptoms, cheilitis and magenta tongue and papular rash. And I will show you some pictures of those. And another interesting thing is if it extravasates, it can cause calcinosis, which is essentially just buildup of calcium in the subcutaneous tissues. So a couple of images of those. This is cheilitis, on the left. There, the cracking and the dry skin on the corners of the mouth. Magenta tongue, this is an image from riboflavin deficiency, but it appears the same. And then this is images of calcinosis from other medical disorders, but understanding that if this EDTA is to extravasate, it can cause buildup of calcium in the subcutaneous tissues. So it's just something to be aware of. It's one of the unusual side effects. So generally, it is infused over a 24-hour period in either D5 or normal saline. It can be given IM. It's rarely done so. It is somewhat painful, and so it's generally recommended to add lidocaine to the injection just due to pain. All right, so move on to DMSA, another one of those short carbon chains. DMSA is dimer capto, so 2 thiol groups. Succinic acid. Succinic acid is a 4-carbon chain with carboxyl groups on either side. So this is one of those short chain ones. This is going to chelate mercury, arsenic, lead. In this case, also there's evidence for cadmium as well. And interestingly, Succimer, which is the brand name, or DMSA, can chelate metals at different sites. So see, cadmium and lead are both chelated between that carboxyl group and the thiol group, and mercury is chelated between the 2 thiol groups. So kind of interesting. It has multiple options to chelate metals. Currently only available orally in the U.S. It is rapidly metabolized. It has a fairly short half-life, and its elimination is in the kidney as well, just like EDTA. Comes in these little capsules with little beads inside, and definitely increases the urinary excretion of mercury, arsenic, and lead as well. So something interesting, this is from a study called the TLC trial, and this was looking at treating children who are asymptomatic with lead concentrations between 25 and 45, to see if they can get their lead concentrations down, and then also for clinical outcomes as well. And I just wanted to show this. It's important that, these children started about 37, 38, and then as soon as you give DMSA, the next week their concentration was about 60% reduced, and that is a typical amount, 50 to 60% reduction. As soon as you stop giving DMSA, the blood lead concentration rebounds up to about 26, 27, something like that. And so you can expect when you start using DMSA on someone with lead toxicity, assuming that they have chronic lead toxicity like most do, that their lead concentration will drop about 60% initially, and when you stop the DMSA, it will end up somewhere in about 30% less than it was to start with. So it gives you some goals and some expectations when you're starting DMSA. This is a trial I was talking about, 780 children. The lead concentration was 20 to 44. I think I misspoke before. And this is their lead concentrations. If you look at the bottom of the screen, people who got placebo, the children who got placebo had this slow decrease in their lead concentration. the people who got Suxima or DMSA had a rapid decrease in their blood concentration that went back up, and then they got treated again and went down, and they came back up. But at the end of a year, their lead concentrations were essentially identical. They were just slightly lower in the, but not statistically significantly so in the treated group. So long term, there was no difference in lead concentrations. They also did a very nice study looking at IQ long term and found no differences in the group in IQ in the group that was treated with Suxima. So we know again that when we're thinking that when we're treating to eliminate a metal from the body, the amount that we get out with chelation is a very, very small percentage. But what it does do is it does rapidly decrease blood concentrations, and if that's important for symptoms, then that's the cases that we use chelation for. They also did 1, 2, and 3 courses and also found no effect at all. So, and nice thing about DMSA is there's no redistribution in the brain. This is a study looking on the left, looking at blood lead concentrations, and the solid line is the placebo group, and then the dotted line was DMSA. So we know that it decreases blood concentrations fairly rapidly. And on the right is a study looking at brain concentrations, and there's no increase in brain concentrations with DMSA. So that is a good selling point for DMSA for treatment for lead encephalopathy, or excuse me, for lead toxicity. The adverse effects are fairly small. It does smell like sulfur, not surprisingly, because it has those 2 thiol groups on it, mostly GI with flatus and nausea, vomiting, diarrhea. It does increase excretion of zinc, copper, iron, calcium, so many people will give multivitamins and supplementation for the chelated medications. The dose, again, is confusing. In children, it's a milligram per meter squared, and in adults, it's a milligram per kilo. And I put both of those doses down there. You can see that when the numbers get up high to adult size, the numbers are fairly equivalent, and so that makes it easier just to switch to milligrams per kilo. But for children, the dosing is quite different if you use the meter squared. So meter squared is generally more accurate, and that is recommended in children. So it comes in these little bead-filled capsules for some small children. They can't swallow capsules, so you can open it up and put the beads in food and things like that, and it's fairly well tolerated. Though again, it does smell like sulfur, and it's a little hard to hide that part. All right, so moving on to some of the less common chelators, DMPS, very similar to DMSA. The structure is on the bottom right there. It's an investigational drug in the U.S., but available in other areas of the world and used for arsenic and inorganic mercury. Probably the key things are it does have an association with Stevens-Johnson syndrome, and it has been tried with copper toxicity but worsened hemolysis. So that is, it's not an indication for DMPS, but it may worsen copper toxicity in those patients, so something to know of. D-penicillamine has been out of production for a very long time. Was used for lead and also copper and arsenic, as well as a couple of medical disorders, including rheumatoid arthritis, scleroderma, and cystinuria. So we probably, unless someone starts to produce this again, we probably won't be seeing much use of this. Did have significant side effects, but more importantly than the mild side effects were very rare occasions of severe side effects like aplastic anemia, SLE, and or SLE-like syndrome, and myasthenia gravis. So there are some reports of patients with penicillin allergies being allergic. Now, if you look at the structures in the upper right there, they don't really look like each other. But if you use your imagination, there is some structural similarity on the right side of penicillin and with penicillamine, and that may be the cause of this cross reaction, but it's something to be careful of. DTPA, most of us will never use, but it's one of these large molecules like EDTA, and its indications are plutonium, americium, and some of the actinides. So unlikely that we will use this clinically, but interestingly, it's also used to chelate a whole bunch of other things like hair products. And when we give gadolinium for MRIs or technetium for nuclear medicine imaging, if you look at the vial, you'll notice that it's a chelated gadolinium, and it's chelated with DTPA. So they actually deliver it as a chelate, and the same with technetium. So for clinical medicine, we're unlikely to see someone with plutonium or americium toxicity, but it is available, and we should know a little bit about its use. It has similar kinetics to others, and it's renally excreted, and the dosing is something we probably just need to look up because we're not going to use this very often. The important part about DTPA is that calcium, there's two different forms. There's calcium DTPA and zinc DTPA. Calcium is more effective. However, calcium leads to zinc depletion and can lead to significant side effects and has led to significant side effects. So generally, the method is to use calcium DTPA for a day because it's more effective, and then switch to zinc DTPA to avoid zinc depletion. So I always think of it as it's alphabetical order. You use calcium first and then zinc second, but calcium for a day and then zinc after that. All right, Prussian blue is a unique chelating agent in that it is a gastrointestinal chelating agent, much like activated charcoal is. Although obviously activated charcoal isn't actually a chelator, but it does adsorb and bind to substances. Prussian blue is given orally and generally travels through the GI tract, binding to the two things it's indicated for, thallium and cesium. No, there's a very small amount that is absorbed because if you give enough Prussian blue to people, they will get some blue discoloration of their tears and things like that. So clearly some is being absorbed, but the vast majority is just traveling through the GI tract. And in animal studies, it does decrease mortality in thallium poisoning. And thallium concentrations are decreased and the half-life is reduced. So this dosing can be is somewhat variable, but the most straightforward thing is in an adult, generally it's 3 grams TID, and in children 1 gram TID. This is not absorbed very much, so using that rule, that sort of 3 grams in adults, 1 gram in children TID, is a reasonable starting place to treat someone. Adverse effects are not very much. There's mostly constipation. Notice that the structure does have a lot of cyanide groups in there. There's a lot of concern that cyanide might be released, but it is in very, very small amounts, but it's not significant. It's not something that should cause symptoms, but you should be aware that Prussian blue is essentially an iron bound to 6 cyanide groups, but generally cyanide is not released or absorbed in any appreciable quantity. And it's got this bright blue color to it. Comes in blue capsules with this sort of blue stuff that kind of looks like charcoal on the inside. All right, deferoxamine is for iron toxicity generally. DFO or deferoxamine, also called desferrioxamine in the literature. Just again, generally used for iron. There's some indications for doxorubicin and aluminum as well. But we know that it does, at least in animal studies, decrease mortality from iron toxicity. This is the one chelator that has a slightly higher volume of distribution. There is evidence that it travels into the interstitial space and hepatocytes. It binds with iron to make ferrioxamine, which has a much smaller volume of distribution, so redistributes to the vascular compartment and then is excreted. So it does bind iron much better than it binds things like zinc and copper, but as with every other chelator, it's always possible that it would bind some of those minerals and metals. The deferoxamine combines with iron to cause to form ferrioxamine, which is pictured on the bottom left. The deferoxamine is on the upper right. Ferrioxamine has a reddish color and is the cause of the vin rosé urine, which is pictured on the bottom right. And if you are producing vin rosé urine, that means that the deferoxamine is finding iron and forming ferrioxamine. Commonly, when the vin rosé urine stops, people have used that as an indicator that deferoxamine can be stopped, at least for a period, because you're no longer binding any iron. Deferoxamine is extensively metabolized and is mostly excreted in the urine. So adverse effects, probably the most common is hypotension. This is likely histamine related, definitely rate related. And so recommendations in the past have been to not exceed 15 milligrams per kilo per hour. That said, many people have exceeded 15 milligrams per kilo per hour in the past, and in fact, and not had hypotension or have handled the hypotension. So, but it's something to be expected. It's the reason why we started a low dose and we slowly increase. We're waiting to see if they have hypotension. And in general, it should be advanced. The dosing should be advanced in as long as they don't have hypotension. Otherwise, long infusions greater than 24 hours or 48 hours can lead to acute lung injury, which has been severe in the past. So it is often a question of whether which one is, it's a risk-benefit ratio evaluation on patients who are very sick with iron, whether to continue the infusion over 24 hours. If they're not very sick, then that decision is a little easier, and you can stop the infusion after that time. It has an unusual association with some infections. These are mostly not with acute overdoses. These are with chronic treatment for iron overload. And so it is not something that we will see with an acute iron overdose that's treated with deferoxamine, but people who are treated with deferoxamine for weeks, months, et cetera. But just so that you know, it's Yersinia, zygomycetes, erymotus, and mucormycosis. All are increased risk when you take deferoxamine. And otherwise, there are ocular toxicities, including color vision loss, peripheral vision loss, and retinal pigmentation, so as well as ototoxicity. So all of these should be considered when we're talking about how much to give and how long to give it. The dosing is generally to start at 5 milligrams per kilo per hour. It is an infusion, and then titrate up to 15 milligrams per kilo per hour. Now, that said, many practitioners have used in very sick patients much higher doses than this, and there is something to be said for infusing it as fast as possible early in the toxicity, because that's when the iron concentrations are the highest, and that's your best chance at chelating that iron. So understand that there's different ways to go about this, and some will titrate up to 15 per kilo per hour, and others will titrate up much higher, 30 or 45 milligrams per kilo per hour, as long as they're not developing hypotension, in order to clear that iron early after the overdose. Generally limited at 8 grams a day. So you can there's a couple of different ways to do it, and some people will give 1 gram and then stop the fast infusion and divide the other 7 grams over 24 hours. I prefer to get to titrate up very quickly up to a point that's not causing hypotension, and infuse as much as we can early on in order to chelate as much iron as we can. It comes as a mesylate. It's a lyophilized powder, and the mixing instructions are there. There are IM uses. This is rarely used, but it is possible. There are other DFO-like chelators. Deferapone was approved in 2011, and deferoxarox in 2005. These are interesting because they bind in a 3-to-1 or a 2-to-1 ratio, and there's pictures of it over on the right side of the screen there. So more chelator, you require 2 or 3 chelators in order to bind an iron, which is pretty interesting. They do have specific toxicities, deferripoin, agranulocytosis rarely, and QT prolongation. So let's just review. We went through a lot of stuff today. Let's just think about kind of grouping things together and what's the take-home message here. There's a bunch of structural similarities in all of these. BAL, DMSA, DMPS, penicillamine are all those short carbon chains with the thiol groups off of them. EDTA, DTPA, deferoxamine, longer chains, bunch of carboxyl groups off of them. So they kind of look different and they kind of act different. BAL, remember peanuts, peanut allergies, it's in peanut oil, it smells like peanuts. And then most of the patients we're going to give this is lead encephalopathy, but it does bind to BAL, binds to MAL, mercury, arsenic, and lead. And then that odd syndrome that they develop a few minutes after with the sludge symptoms and the hyperthermia. Bicarbonate can ion trap the chelate and don't give iron. EDTA is used generally for lead, for severe lead. You can get nephrotoxicity and can develop zinc deficiency. DMSA is got very few side effects. It's used for mercury, arsenic, lead, MAL, and cadmium. And DMPS, similar to DMSA, but it does have those two odd side effects of Stevens-Johnson syndrome and worsening hemolysis. DTPA for those odd radioisotopes, americium, curium, plutonium. Remember, alphabetical order, calcium first, then zinc. And then Prussian blue is that oral one that kind of looks a little like charcoal, like blue charcoal, and that is used for thallium and cesium. Deferoxamine for iron and aluminum. It's deferoxamine plus iron equals ferrioxamine, which causes the vin rosé color. And don't forget rate-related hypotension and acute lung injury or ARDS. So that's all I have to talk about chelators. These can be somewhat confusing, but once you kind of can group things together and then split them apart a little bit, they get much easier. I hope my discussion helps better on your understanding of chelators. Thanks.